Good morning, doctors. Today we are on our 22nd day of reading Oxford Handbook of General Practice, and I'm Dr. Sesha, your study buddy, and we are preparing together for MRCGP International AKT exam. We are at page number 470. Today's topic is musculoskeletal problems, ankle and foot problems. Let's start reading. History. History of trauma. So you have to ask history in ankle and foot problems, history of any trauma, increased activity like are they walking recently or running a long way for the patient, feeling of instability, pain or stiffness in relation to weight bearing, localized or diffused, deformity, problems getting shoes or shoe wear in odd places or shoes are always uncomfortable, interfere with activities. So examination. Compare one foot with the other. Watch the patient walk normally on a tiptoe. Look at the foot with the patient seated. Check for deformities, the color of the foot and any skin and nail changes. Check for the shoes for any abnormal patterns of wear. Wear is normally under the ball of the foot. So this is wear and tear. Wear and tear of your shoe. If at all it's normally the wear is under the ball of the foot medially and posterolaterally at the heel. So if it is abnormal pattern is there in the wear and tear, then also you have to have a look. Feel. Is there any tenderness? Palpate any swellings. Check the pulses and skin temperature. Move. Assess active and passive movements of the ankle, subtalar, mid-tarsal and toe joints systemically. Check the range of movement of joints and pain. Neurology. Check the sensation if the patient reports any loss of sensation. Ankle, foot and toe fracture. We will see in page 1093. Achilles tendonitis. Inflammation of the Achilles tendon may be related to overuse or spondyloarthropathy. Presence as painful local swelling of the tendon. Advise rest. NSAIDs, heel padding, physiotherapy plus steroid injection may help. Never inject the steroid into the tendon. If persistent, refer to rheumatology. Ruptured Achilles tendon. Presents with a sudden pain at the back of the ankle during activity felt as a kick. The patient walks with a limp and there are some walks with a limp. There is some plantar flexion, but the patient cannot raise the affected heel from the fold when standing on tiptoe. So that's why initially you have to check whether he can stand on a tiptoe and walk. A gap can usually be felt in the tendon. Calf squeeze test is negative. Squeezing the calf muscle results in movement of the foot if Achilles tendon is intact. Refer immediately for consideration of repair. The alternative is immobilization in a splint with the foot in plantar flexion. Pes cavus. High foot arches may be idiopathic due to polio, spina bifida, or other neurological conditions. Toes may claw. Padding under the metatarsal heads relieves pressure. Operative treatment. Soft tissue release or arthrodesis straightens the toes. Can lead to tarsal bone osteoarthritis causing pain. Refer for fusion. If there is osteoarthritis of the tarsal bones, then you need to refer them for fusion. Foot drop. Patients trip frequently or walk on a high stepping gait. On examination, the patients are unable to walk on the heels and cannot dorsiflex their foot. Check for the ankle jerk. Causes of foot drop. Common is common peroneal palsy, common peroneal nerve palsy. Example, due to trauma, normal ankle jerk will be present. Sciatica, ankle jerk will be absent. L4 L5 nerve root lesion, ankle jerk may be absent. Peripheral motor neuropathy, alcoholic ankle jerk weak or absent, distal myopathy ankle jerk weak or absent, motor neuron disease there is exaggerated ankle jerk. So these are the causes of foot drop: common perineal palsy, sciatica, L4 L5 nerve root lesion, peripheral motor neuropathy, distal myopathy, and motor neuron disease. Club foot, talipus, consists of inversion of the foot, adduction of the foot, inversion of the foot and adduction of the forefoot related to the hind foot, equinus and equinus, plantar flexion. So there are two components. One is inversion of the foot and adduction of the forefoot, and equinus, that is plantar flexion of the foot. Positional talipus. Molding deformity seen in neonates. The foot can be passively everted and dorsiflexed to the normal position. Treatment is with physiotherapy. Follow up to check the deformity is if the deformity is resolving. True talipus. The foot cannot be passively everted and dorsiflexed to the normal position. Refer to the orthopedics. Treatment is with physiotherapy, splints or surgery. Flat feet, pes planus. Low medial arch. All babies and toddlers have flat feet. The arch develops after 2 to 3 years of walking. Persistent flat feet may be familiar or due to joint laxity. If pain-free, the foot is mobile and the patient develops an arch on standing on the tiptoe. Flexible foot. No action is required. If painful, may be helped by an analgesia, exercises or insoles. For severe pain, hind foot fusion is an operation. Refer if the arch does not restore on tiptoeing. So when do you have to refer in the case of a flat feet? If the arch is not restored on tiptoeing. If the patient is asked to tiptoe, you should be able to see an arch. But if it's not there, then you have to refer to the orthopedician. In-toeing and out-toeing gait. In-toeing. In-toeing originates from the femur, either persistent anteversion of the femoral neck, the tibia due to tibial torsion, or the foot, metatarsus varus. Does not cause pain or affect mobility, usually resolves by the age of 5 to 6 years. Out-toeing. Common in less than 2 years of age, may be unilateral, correct spontaneously. So out-toeing you don't have to bother at any age, and in-toeing you should bother when it is not resolved after 5 to 6 years. Usually it will resolve by 5 to 6 years. Sever's disease. Apophysitis of the heel. Peak age of onset is 8 to 13 years. Treated with analgesia, raising the heel of the shoe a little, calf stretching, and avoiding strenuous activities for a few weeks. Analgesia, raising the heel of the shoe, calf stretching, and avoiding strenuous activities for a few weeks. Osteochondritis, syndactylity and polydactylity. Osteochondritis of the foot in children and young adults. The types are Kohler's disease, navicular bone osteochondritis. Peak age of onset is 3 and 5 years. Presence with a pain and tenderness over the dorsum of the midfoot. A X-ray will reveal small navicular bone of increased density. Pain usually resolves with simple analgesia and rest. Freiberg's disease. Second and third metatarsal heads. Most common in teenagers and young adults, females more than males. Presence with pain in the foot on walking. The head of the metatarsal is palpable and tender. X-ray shows wide, flat metatarsal. Treatment is usually conservative with cushioning of the shoes and simple analgesia. If severe, refer for orthopedics. Excision of the metatarsal head may relieve the pain. Tender heel pad. A dull throbbing pain under the heel develops a few months after a heel trauma, may be due to plantar fasciitis, bursitis or tendonitis. Treat with rest and heel padding. Refer to physiotherapy. Okay, when there is a tender heel pad, it can be plantar fasciitis, bursitis or tendonitis. Heel pad pain. Refer to physiotherapy. Ultrasound can help in treatment. Blind steroid injections into the fat pad are not recommended. In persistent cases, refer to rheumatology. Plantar fasciitis or bursitis. Common cause for inferior heel pain, especially among runners. Pain is worst when taking the first few steps after getting out of bed. Yes, in plantar fasciitis, pain is worse after taking the first few steps out of the bed, usually unilateral and generally settles in less than 6 weeks. Advise shoes with arch support, soft heels and heel padding. That is trainers. Achilles tendon stretching exercises will help. NSAIDs and steroid injections are also helpful. In persistent cases, refer to podiatry for fitting of an insole plus orthopedics. Plus or minus orthopedics. Fasciitis or bursitis. Metatarsalgia or forefoot pain may be due to synovitis, stretch fractures, sesamoid fractures, injury, or increased pressure on the metatarsal heads due to mechanical dysfunction, as in rheumatoid arthritis. Treat with insoles and padding under the metatarsal heads. Surgery may be helpful in rheumatoid arthritis. Discuss with rheumatologist. Morton's metatarsalgia or Morton's neuroma or interdigital neuroma, the pain due to entrapment of the interdigital nerve between third and fourth metatarsal heads. Usually, gradual onset of sudden attacks of pain or paresthesia during walking. Refer to orthopedics. Treatment is with steroid injection and advice regarding footwear. Some need surgical excision of the neuroma. Hammer and claw toes. Hammer toe and claw toe. See, this is hammer toe. Looks like a hammer. This is claw toe. So in hammer toe, only the proximal interphalangeal joint is in flexion and distal is in extension. Whereas in claw toe, both proximal and distal interphalangeal sorry, let's read the explanation. Hammer toe, there is extended MTP joint, metatarsophalangeal joint, hyperflexion of the PIP joint and extended DIP joint, most common in second toe. So this is extended metatarsophalangeal joint, hyperflexion at the proximal interphalangeal joint and again extension at the distal interphalangeal joint. So this is called hammer toe. Claw toes, there is extended metatarsophalangeal joint. This one should be extended just like this. Flexion at the PIP joint and DIP joints. Yeah, as I said, extension at the metatarsophalangeal joint and flexion at the PIP and flexion at the DIP joints. So, hammer toe, most common in the second toe, like in this picture. Just remember this picture. Claw toes, extended MTP joint, flexion at the PIP joint and distal interphalangeal joints due to imbalance of the extensors and the flexors after a polio. If causing pain or difficulty with walking, footwear, refer for surgery. Achilles tendon stretching exercises. Towel stretch. Sit on the floor with your legs stretched out in front of you. Loop a towel around the top of the injured foot. Slowly pull the towel towards you. Keep your body straight. Hold for 15 to 30 seconds and relax and repeat 10 times. This is Achilles tendon towel stretch exercise. Calf Achilles stretch exercise. Stand facing a wall. Place your hands on the wall, chest high. Move the injured heel back with the foot flat on the floor. Okay, so you need to move your injured heel back with foot flat on the floor. Move the other leg forward and slowly lean towards the wall until you feel a gentle stretch through your calf. Hold for 15 to 20 seconds and repeat. You need to try these exercises yourself, then you will remember them well. Stair stretch. Stand on the step or on a step on the ball of for your feet. You stand on a step on the balls of your feet and hold the rail or wall for balance. Slowly lower the heel of the injured foot to gently stretch the arch of your foot for 15 to 20 seconds. That is stair stretch. Toe stretch. Sit on the floor with the knee bent. Pull the toes back on the injured foot until the stretch is felt across the arch. Hold for 15 to 20 seconds and repeat. Frozen can roll. Can roll. Roll your bare injured foot back and forth from the tip of the toes to the heel over a frozen juice can, not frizzy, or small plastic water bottle. This is a good exercise after activity because it both stretches the plantar fascia and provides cold therapy to the injured area. Hmm. Okay. Hallux valgus or bunion. Lateral deviation of the big toe at the metatarsophalangeal joint exacerbated by wearing pointed shoes like high heels. Plus high heels. Pointed shoes and high heels. A bunion develops where the MTP joint rubs on the footwear. Arthritis at the MTP joint is common. Bunion pads can help, but severe deformity requires surgery. Hallux rigitus. Arthritis at the first metatarsophalangeal joint causes a stiff, painful big toe. Refer severe cases to podiatrist or orthotist for offloading or custom-made rocker bottom foot orthosis. Resistant pain requires surgery. So this is stiff and painful big toe. So you need to refer to an orthotist or a podiatrist for offloading or custom-made rocker bottom foot orthosis. Resistant pain requires surgery. Hallux rigitus. Ingrowing toenail. Most common in the big toe. Ill-fitting shoes and poor nail cutting predisposes the nail into the ingrowing toenail. Most common in the big toe. Ill-fitting shoes, poor nail cutting predispose the nail growing into the skin, causing pain. The inflamed tissue is prone to infection. Advice about cutting the nails: cut straight with the edges beyond the flesh. Refer to podiatry. Treat infection with antibiotics, example flucloxacillin 500 mg QDS. If recurrent infection, consider referral for surgery, example wedge resection of the nail. Antibiotics you give for nail infection, ingrowing toenail is flucloxacillin. So next topic is sports medicine, page number 474. Fitness to perform sporting activities. GPs are commonly asked to certify fitness to perform sports. Normally the patient will come with a medical form. If there is a form, request to see it before the medical. If there is no form, you are unsure what to check, telephone the sports governing body or the event organizer. A fee is payable by the patient. Many gyms or sport clubs also ask older patients or patients with pre-existing conditions or disabilities to check with the GP before they will sign them on. Assuming that a suitable regimen is undertaken, most people can participate. Consider the patient's baseline fitness, check the BP and medications, recommend a gradual introduction to new forms of exercise. Remember, signing a form may result in legal action against you should the patient not be fit to undertake an activity. Where possible, include a caveat. Example, based on information available in the medical notes and the patient appears to be fit to dash, although it is impossible to guarantee this. Okay, you have to write in this format. If unsure, consult your local LMC, Medical Authority Indemnity Organization. Medical Indemnity Organization. Hypertrophic obstructive cardiomyopathy can cause sudden death during sport. It is difficult to exclude on clinical examination. If there is a family history or a systolic murmur, refer to cardiology before recommending new intense activity. Benefits of exercise. Children and sport. Exercise is good for children. It stimulates development of musculoskeletal and cardiovascular system. It should be fun and not physically or emotionally over-demanding. Children are more prone to sports injuries due to continuing growth. Bone growth plates are prone to damage, but are more flexible, so they have less injury rate. Children's temperature control is not as good as adults. Equipment must be checked regularly to ensure it fits. Encourage a warm-up stretching exercises before the sport. Refer the children with suspected overuse or sports injuries which do not recover rapidly with simple analgesia for specialist assessment. Mhm. Nutrition. Recommend a normal varied diet. Nutrition. Normal varied diet. Special circumstances. Particular sports have special requirements. Increased protein for strength in athletes. Increased muscle glycogen stores before exercise can decrease fatigue during prolonged heavy exercise. Carbohydrate loading 3 to 4 days of increased carbohydrate 8 to 10 grams per kg body weight. 8 to 10 grams per kg body weight. So for a 60 kg person, it will be 600 grams. So of increased carbohydrate intake and a carbohydrate meal 3 to 4 hours before competing will load the glycogen stores, increase the muscle glycogen stores before the exercise. Oh, carbohydrate loading and carbohydrate meal before competing. Fluids. Sufficient fluid during exercise is vital to good performance and health, especially in hot conditions. Rehydration fluids containing carbohydrate and electrolytes are absorbed faster than plain water. Okay, supplements. Vitamins, minerals, amino acids, carnitine and creatinine. A good diet generally supplies sufficient nutrients. Drugs and sport. Most regulating bodies have strict codes regarding drug use. Regulations may differ between different sports. Status of particular medicine may be checked in the Global Drug Reserve online. Prohibited class of drugs. Any stimulants, example amphetamine, caffeine about 12 micrograms per ml, ephedrine, certain beta-2 agonists, inhaled medication for asthma is allowed. Otherwise, certain beta-2 agonists are not allowed. Narcotics. Morphine, diamorphine, petidine, methadone, codeine is allowed. See, codeine is allowed. But the rest of the narcotics, morphine, diamorphine, petidine, methadone are not allowed. Okay. Anabolic steroids, nandrolone, DHEA and testosterone are not allowed. Diuretics, furosemide, benzoylflumethiazide are not allowed. Hormones, hormone antagonists and related substances like growth hormone and erythropoietin are not allowed. These are prohibited. Cannabinoids are not allowed. Class of drugs subjected to restrictions. Alcohol and marijuana. Alcohol and marijuana restricted in certain sports. Local anesthetics. Local or intra-articular injection only are allowed provided written notification of administration. Corticosteroids. Topical, inhaled or local intra-articular injection only are allowed provided written notification of administration. Beta blockers restricted in certain sports. Drugs for pain relief. Generally, paracetamol, all NSAIDs and codeine are allowed for pain relief. Stronger opioids and drugs containing caffeine are banned. If in doubt, check the global drug reference before prescribing. Anabolic steroid misuse. A significant problem in the UK, 5% in gyms and fitness clubs. Drugs are often used in complicated regimens at high doses to increase the lean muscle mass and decrease the body fat. Side effects include rise in cholesterol, high BP, high cholesterol, high BP, gynecomastia, abnormal liver function test, testicular atrophies, baldness, acne, mood changes. Other drugs may be taken in conjunction with anabolic steroids to decrease these side effects. Okay. Doctors who prescribe or collude in the provision of drugs or treatment with intention of improperly enhancing an individual's performance in sport risk losing their GMC registration. This does not preclude the provision of any care or treatment where the doctor's intention is to protect and improve the patient's health. Page number 476, Management of Sport Injuries. Principles of managing sport injuries. First aid. Airway, breathing and circulation. Refer for severe injuries to accident and emergency. Then rise. Rest, ice, analgesia. C is compression and E is elevation. Relative rest to the affected part while continuing other activities to maintain overall fitness. Ice and analgesia use immediately after injury. Wrap ice on it in a towel and use for maximum 10 minutes at a time to prevent acute cold injury. Compression. Tapping or strapping can be used to treat decreased swelling and also to prevent acute sprains and strains. Elevation. Decrease in local swelling and independent edema enabling quicker recovery. So you have, it is rise. So first airway, breathing, circulation, then rise, then confirm the diagnosis, clinical examination and X-ray. Early treatment according to cause, do not delay. Liaise. Liaise with sports physician, sports physio and coach if allied athlete. Sports physician, sports physio and coach if he is an allied athlete. Rehabilitation. Regarding fitness, strength and flexibility, examine and correct the cause of injury, poor technique or equipment. Graded return to activity, discuss with the coach. Prevention. Suitable preparation and training. Suitable footwear, warm up, warm down exercises, safety equipment can decrease the likelihood of further injuries. Muscle injuries. Hematoma within or between the muscles can be dramatic whole limb bruising due to tracking of blood and stiffness. Treat with can be within or between the muscles, which can be dramatic whole limb bruising and stiffness. Treat with the RICE regimen, encourage movement in a pain-free range. Okay. Strain, hamstrings injury. Refer to physiotherapy. A secondary injury is likely if the patient returns to sports too soon. So, these are muscle injuries, then ligament injuries or sprains. Grade 1 sprain, local tenderness, normal joint movement, give NSAIDs, support strain, encourage mobilization. Encourage mobilization in grade 1 ligament injuries. Grade 2 ligament injuries. Slightly abnormal joint movement is there, more joint protection. NSAIDs elevate the limb, encourage middle of the range of movement. Middle of the range of movement, not the complete range of movement. Grade 3. Abnormal joint movement, refer to orthopedics. Groin pain in athletes. Consider conjoined tendon pathology, Gilmore's groin, symphysitis, footballers notably symphysitis, adductor tendonitis. Adductor tendonitis. So there is groin pain in the athletes. You have to consider if it's a conjoined tendon pathology, Gilmore's joint, symphysitis, footballers, and adductor tendonitis. Lies with sports medicine physician or physiotherapist early. Overuse injuries. Incidence is increasing due to increasingly intensive training regimens, especially in young adults, even among amateurs. Causes. Load too great for conditions, poor technique or posture, faulty or poor quality equipment. Types of injuries. Stress fractures, joint tenderness or effusion, ligament and tendon strains and muscle stiffness. Types of injury: stress fractures, joint tenderness or effusion, ligament and tendon strains, and muscle stiffness. Management: rest, NSAIDs, physiotherapy, improved training regimen, prevention. Recognize and correct poor posture or technique. Check the equipment is appropriate and fits. Warm up and stretching before the exercise and gradually increasing intensity and duration of training. So this one is for ligamentous injury. Rest, NSAID, physiotherapy and improved training regimen. Shin splints. Exercise-related shin pain may be due to stress fracture of the tibia, compartment syndrome or periosteoitis. Fractures are not always seen on the X-ray and bone scan is more sensitive, shows periosteoitis. Treat with rest, analgesia. Consider referral to sports physiotherapist. Iliotibial band syndrome. Pain due to inflammation of the synovium under the iliotibial tract from rubbing on the tract on lateral femoral condyle. So iliotibial band syndrome is seen near the femoral condyle, on the lateral femoral condyle, where there is pain and inflammation of the synovium under the iliotibial tract from rubbing of the tract on the lateral femoral condyle. Seen in the runners. Treat with rest, NSAID, specialist physiotherapy plus steroid injection. Overtraining syndrome, poor performance, fatigue, heavy muscles, and depression due to excessive sports training or competing without sufficient rest. Usually diagnosed from history, exclude other causes. Manage with rest, reassurance, and alteration of training program. Scrumpox or herpes gladiatorum. Herpes simplex virus is very contagious and outbreaks among sporting teams are common. Example: spread by close contact and facial stubble grazes while scrumming. Treatment: acyclovir cream or tablets and exclusion of infected players. Okay, you have to exclude infected players. Impetigo, erysipelas and tinea barbae can be transmitted in the same way. Impetigo, erysipelas and tinea barbae can also be transmitted by close contact sports. Environmental factors: heat cramps, painful spasm of heavily exercised muscles, calves and feet due to salt depletion. Treatment: rest, massage of the affected muscle and fluid and salt replacement. Diurolite. Heat stroke or exhaustion. Exercising in excessive heat, salt and water depletion, dehydration, metabolite accumulation. Signs are: there is headache, nausea, confusion, incoordination, cramps, weakness, dizziness, and malaise. Eventually, thermoregulatory mechanisms fail, leading to seizures and coma. Signs: flushing, sweating, and dehydration. Temperature may be normal in mild cases or increased. Treatment: rest, fluid, salt replacement, diurolite. Admission for IV fluids and supportive measures in severe cases. Hypothermia. Ensure appropriate clothing and limited time in cold. Signs are behavior change, incoordination, clouding of consciousness. Treatment: remove from the cold environment. Wrap in blankets, including the head, and transfer to a hospital. Do not use direct heat. Frostbite: freezing of the peripheries, usually the feet, the hands, the ears, or the nose. Tissues become hard, insensitive, and white. Treatment: gentle rewarming. Refer for significant Refer if significant dead tissue is present. Debridement is usually delayed to allow natural recovery. Diving: decompression illness is due to rapid ascent causing nitrogen dissolved in the blood to form bubbles, usually less than 1 to 36 hours after surfacing. Presentation: deep muscle aches, joint pains, skin pain and paresthesia, itching and burning. Deep muscle aches, joint pain, skin pain, paresthesia, itching and burning sensation and retrosternal pain, cough and breathlessness. Again, there are neurological symptoms also. Refer suspected cases urgently to accident and emergency. So if any person has went for diving and then after within 1 to 36 hours he is coming with any of these symptoms, muscle aches, joint pain, skin pain, paresthesia, itching, burning, retrosternal pain, then you need to refer immediately to accident and emergency. So we'll stop here, doctors, today, and we'll continue tomorrow from page number 478. Thank you. Have a good day.